Good evening. We have with us Dr. Pratik Kumar Mitra, MD, FNB in Critical Care, HCG Ecos Cancer Center, Kolkata. We welcome you to Natco Pharma Specialty Studio, and we look forward to listening to your insights in the space of critical care, which is associated with bacterial resistance. My very first question to you is, how do you foresee the changes in the critical care management space?
In critical care, when I have started my training since my MD days, and till in for last 10 years, there are a lot of changes. Like we started with a lot of fluid, and there are many more parameters, and day by day more invasive thing. Like we have the major things on the antibiotics and fluid management. So this is the basic two thing. The I can say the backbone of our critical care management, and it also the depend on the disease specific thing. Although, but in the fluid management as well as in antibiotic policy, there are a change a lot of, like there are more older antibiotics again brought back to the in our present treatment, where we are facing the resistance in the concurrent medications. And also in the fluid management, also in the septic shock management, like earlier we have to we are in the middle time, we sometimes have been asked to use more of invasive like flow track, lead flow, everything, but with a lot of limitations is there also. And but again, back to basics only, we have to be more clinical. Along with that, we need to be use very basic steps to assess the fluid therapy, like only the arterial waveform. Otherwise, as because in the every all the procedure we have, all the methods we have, it is very complex with a lot of pros and cons. So more we able to stick to the basics to manage the patient. And in my belief, as a critical care consultant, less intervention we do, and this is the best for the patient. And we need to be goal directed. I mean, of course, and the antibiotics thing, antibiotic although in the present era we have the PCR assessment, where we are able to get the hold of bacterial resistance and the genes in less than 24 hours. And when in the time when we at that point of time, we didn't want to wait for the culture report to come. We just send the PCR value, and as per the report we proceed. So in the present time, we have the scope to treat the patient in a less time with the available test. So that's why, and in that way, our antibiotics should be of less time duration, and I think it's a good thing. I think.
So I think in major fields, they always say stick to basics, and you are saying the same, stick to basics. What is the advice you would want to give your colleagues out there who are in the ICU for them to enhance patient care?
Like for every issue, there is some specific bacteria is there for each and every issue, and our empiric management should be based on the standard protocol of there are many guidelines. It might be CDC guideline, it might be the IDSA guideline, but uh, apart from empiric therapy, as long we our treatment go on progresses, we have to stick to our own ICU's antibiogram. In that way, our antibiotic choice should be based on that only. In that way, there will be a minimal use of antibiotics, and it will help us to save some for our future.
Great. What is the prevalence of carbapenem producing bacteria in your practice? What are the treatment options?
Mostly, we have E. coli and Klebsiella, and some are Acinetobacters. These three I commonly face in my ICU. In and but in onco ICU, there are, apart from carbapenems also, there are many other bugs is there. But in carbapenems, as per I usually try to go with the modern trends of sparing the cholestins, and more use of the other medicine, that like for ceftazidime, avibactam, with this thing. In that way, we are able to spare the polymyxins. In that way, we can have something for the future. And also there are many things is on the line. I think sparing the polymyxin, what I practice for my ICU, sparing the polymyxins thing, and correct duration of antibiotics, and based on the standard protocol of infection parameter like procalcitonin and all in that way.
Dr. Mitra, thank you so much for your time in the studio this evening, and we wish you all the best in your practice.